Hello, everyone, and thank you again for joining us at Good Samaritan Hospital for the next in series of video classroom lectures. Today, I'm going to give a brief overview of the non-surgical treatment for aortic valve disease, in particular, TAVR for aortic stenosis. Now, TAVR is an acronym. It stands for transcatheter aortic valve replacement, whereby an artificial valve can now be inserted into the heart through an artery in the leg on the end of a catheter, obviating the need for major open heart surgery. And this has been a critical advancement in the care of aortic valve disease over the past few years. Now, before I talk about TAVR, I'd like to, as I've done in the past, review some of the cardiac anatomy. You know that the heart has 4 chambers. All of these chambers are separated by doorways that we call valves. Deoxygenated blood returns to the heart, comes back into the right atrium, then passes to the right ventricle through a tricuspid valve. The right ventricle, in turn, then pushes this deoxygenated blood through the pulmonic valve into the lung circulation, where it picks up oxygen. It then returns to the left side of the heart into the left atrium, passes through the mitral valve into the main pumping chamber, the left ventricle. The left ventricle then squeezes down to push this big volume of blood to the entire body to bring oxygen and nutrients, and as it does so, the front door, or aortic valve, swings open. Now, this aortic valve is made up of 3 doorways, or cusps, as we call them. On the left, you see what the valve would look like in its normal position of being open and closed as the left ventricle squeezes. Over the course of years, in many people, and I'll get into this shortly, the aortic valve or cusps begin to get calcium deposited on them. And as it does so, the valves get stiffer and stiffer, making it harder and harder for the left ventricle to open that valve, push it open, and expel its blood. Over the course of time, if that gets tighter and tighter and becomes critically stenosed, symptoms will evolve, and your lifespan, if uncorrected, is shortened. Now, aortic stenosis, if it's mild or moderate, even moderately severe, will really not result in any new symptoms. You wouldn't feel that at all. And in fact, if it stayed that way, the heart would function normally. Actually, it would basically do its job without any shortening of lifestyle. However, if that stenosis becomes critically tight with a very small opening, eventually that left ventricle will fail, and symptoms will start to give a warning sign. Once you start having symptoms, the clock starts. At that point, it's been shown, if uncorrected, 50% of the people will lose their lives within 2 to 3 years. The classic symptoms of progressive, severe aortic stenosis take one of these 3 forms predominantly. First, you may experience new shortness of breath with activity that you were doing before and never had a problem with. Or you may get new chest pains with activity, not indistinguishable from typical angina pains that one might get with blockages. Or one may present just with new recurring dizziness or even fainting spells as the first clue that the aortic valve is severely stenotic. Now, aortic stenosis turns out to be very, very common. In fact, it's estimated that 15% of people over the age of 75 actually have aortic stenosis, 1 out of 8. And this is a major healthcare problem because of the volume, and will continue to be so because the population will continue to grow over time. And as it's estimated by the year 2050, there'll be 80 million people in this country over the age of 75. And if we do the math, we can see that 8 to 10 million people will have significant aortic stenosis at that time. Now, there are 3 different causes for aortic stenosis. First and foremost, the most common, is calcific aortic stenosis, the classic aortic stenosis that occurs with time and age. But then there's bicuspid aortic stenosis, which is a congenital abnormality of the aortic valve where one is born with two doors or two cusps functioning rather than three. It turns out that this distorted architecture of the valve with turbulence of blood flow over the years results in a faster calcification of the valve than would normally take place. And they can develop signs and symptoms at a younger age. And then finally, one can get severe aortic stenosis in their life if, as a child or young adult, they've had rheumatic fever, which is an infection with a streptococcus bug. At that time, that particular disease is associated with intense inflammation of all the valves of the heart. Then, long after the streptococcus bug is gone and the infection is gone, that valve, in this case the aortic valve, continues to scar down quickly over time and at a young age may present with valve dysfunction, whether it's stenosis or leaking. Now, calcific aortic stenosis, as I said before, is an age-related problem. It is the most common cause of aortic stenosis. But it's not only reflective of age, there's also a genetic component. If one has first-degree relatives that have been treated or have severe aortic stenosis, the likelihood that they or other family members will get it will be higher than the normal population. Again, this is a progressive calcification of the valve. Symptom onset for severe aortic stenosis occurs late in life, generally beyond 70 years of age, not uncommonly in the 80s. Then there's bicuspid aortic valve, where one is born with two rather than three cusps. As I mentioned before, calcification of the valve occurs at an accelerated rate when there's this turbulence of blood flow, such that severe aortic stenosis, if it occurs, will occur earlier in life, in their 50s, and they may require an intervention at that age. And then finally, rheumatic aortic stenosis occurs even earlier. After that infection as a child or young adult, that fibrosis and scarring accelerates very quickly. And if they do develop aortic valve problems, it generally occurs in their 40s that will require intervention at a very young age. Now, how do we manage aortic stenosis? In the old days, well, not so old, just years ago, the only way to take care of this valve was to replace it. There is no medication that can reverse aortic stenosis. As of years ago, the procedure that was done would involve open heart surgery. You just literally had to crack open the chest and replace the valve. Now, there are two different kinds of valves that can be used to replace the diseased valve. Each one has advantages and disadvantages. First is the mechanical valve. The mechanical valve made from artificial material. This one has the advantage over biological valves from pigs or cows or cadavers in that it is much more durable, lasts a long time. The likelihood that this valve will need to be replaced again after it decompensates may not be seen for a good 25, sometimes 30 years. The downside of this valve is this artificial material attracts blood clots. And people with mechanical valves need to be on major blood thinners for the rest of their life. And you know that those are associated with significant complications, blood thinners where they can have bleeding complications, sometimes life-threatening. Then there's the biological valves, valves that come from cows or pigs or cadavers. The advantage of these valves is that they do not require blood thinners and therefore would not have any complications related to blood thinners for the rest of their life. However, they're not as durable. It is not uncommon that if you have a biological valve, it'll degenerate over time and you will need a second surgery in 15 to 20 years. Now, up until several years ago, these two valves again had to be put in through surgery. But several years ago, they developed a very successful technique where they could place the biological valve through the groin without doing surgery, a valve that's stuck on the end of a catheter and placed in position. Now, this aortic valve replacement, as I said, is on the end of a catheter threaded up through the leg, up through the aorta, around the aortic arch, and positioned within the aortic valve. It is crimped down over a balloon. When it's in the proper position, the balloon is expanded. The valve expands, stays in place, locks in place. The balloon is then deflated and, along with the catheter, removed, and left in place is this artificial valve inside the apparatus of the three cusps that originally should be there. The old valve is literally pushed up against the wall and no longer in play. Now, it's obvious that a non-surgical replacement of the aortic valve or a TAVR is clearly could be superior to surgical valve replacement for many reasons. Obviously, it's less invasive. You have no scar. It only takes an hour to put in as opposed to 4 to 5 hours in the operating room. Your hospital stay is much shorter, 3 days versus an average of 7 days with surgery. Recovery time is clearly shorter if there's been no surgery. You have less pain, less anxiety. Turns out that the clinical outcomes long-term, now that we're getting more and more data, we were hoping would be at least as good as surgery, but in fact, they're even a little better. The annual mortality or stroke rate after putting in a TAVR valve is under 1% compared to stroke, which is under 3%. Quality of life is significantly improved with TAVR, and people can return to a normal lifestyle, normal activity at a much shorter time, much more quickly. Now, nothing comes without a price. TAVRs are still invasive. We place a thick catheter in major arteries to get it up to the heart. You can get damage to the aorta. You can flick off a plaque from the aorta, which can embolize. It can go up the brain and cause a stroke. Or if it goes down an artery to the heart, a coronary artery, it could result in a heart attack. The valve, if it's malpositioned or the wrong size for the aorta, could not function properly and result in a severe leak, which also can result in heart failure, requiring intervention or surgery anyway to fix. Now, because we're poking in a major artery in the leg, there are bleeding complications that we always worry about. And some of these bleeding complications can be life-threatening. The aortic valve anatomically is right next to a major part of the electrical system in the heart. Consequently, when you expand the prosthetic valve in that position and squeeze against that particular apparatus, you can develop rhythm abnormalities that will require a pacemaker. In fact, that's not terribly uncommon. It's estimated that about 10 to 15% of people having a TAVR will require a permanent pacemaker either during the hospital stay or within the first 30 days. And then there's always the fear that something goes wrong with TAVR and you have a major problem that requires emergency open heart surgery, which is always fraught with additional problems. Having said that, not to scare you, all these complications are still very rare, and compared to not fixing the valve, clearly are much better. In fact, if we go to the bottom of this slide, which is really the more important number, the all-cause mortality or significant stroke rate in this series after placing a biological valve through the groin was really well under 1%. We only see that maybe in 1 out of every 200 people. Now, surgery also has a very low complication rate compared to not doing surgery and letting things evolve naturally, but that complication rate is higher than what we see with a TAVR. Now, aortic stenosis is not the only reason for needing a valve replacement or getting a TAVR. You could be born with anatomical problems with the valve, or infections could develop on the valve that cause severe leaking, not stenosis, but leaking. These particular problems can also be treated through a valve replacement through the groin, where in the old days you had to open up the chest. In addition, if someone has a surgical valve from years ago, say a biological valve, and if that valve is failing, like it can do over 15, 20 years, in the past these people would need a second open heart surgery, always fraught with more problems than the first one because of all the scarring in there. Now we can fix that valve with a TAVR without doing another surgery. Clearly a major benefit. So in the end, I just want to leave you with the fact that aortic stenosis is a very, very common problem as we get older. And if the valve problem is fixed in a timely fashion at the appropriate time, prognosis is excellent. But you have to recognize if you have that problem. So you must be tuned into your symptoms. You must clearly seek consultation with your primary care physician or cardiologist if you're noting excessive fatigue over the recent 6 to 12 months, shortness of breath, again, with activity that you normally were able to do, or new chest pains that you are ill-defined. If you were able to walk and do things that you no longer can do for various reasons, it may be due to a valve problem. If you're suddenly getting dizzy or fainting, all these things could be due to a severe aortic stenosis, which as you get older, is more likely to happen. Now, these are non-specific symptoms. You'll see them with other problems, both in the heart and other parts of the body. But if you have them, seek medical care. It is simple to differentiate between aortic stenosis and other causes. Simple tests, the most common of which is a sonogram or echocardiogram of the heart, where the physician can see it and know right away if you're dealing with a valve problem. So, I'll leave you with the fact that if you or any of your family members have aortic stenosis of severity, and you really want more information, more in-depth information from what I've told you, I'll leave you here with some websites that you can access that'll be very satisfactory and give you all the information you need. I'll leave them on my slide set here. They'll be available on our website for you to look at. In addition, any information you need more, you can always reach us by calling 631-376-4444 or visit our website at www.good-samaritan-hospital.org. Again, thank you very much for joining us again for our video class conferences. I look forward to seeing you again for the next one.